We are a private research team and have been working with Neurofeedback since 2008. Since then, we have collected approximately 8,000 clinical EEG records. Gradually, this has enabled us to identify neurological patterns associated with dissociation and ADHD. Today, we would like to introduce these patterns to you. They are based on frequency and amplitude, two parameters that can help us describe a client's symptoms with remarkable accuracy. In practice, this can guide us in selecting the appropriate training approach for each individual client. It also helps us understand what kinds of changes we can realistically expect. This lecture is based on the work of my wife, Bibiana Dobrovolna. My name is Yaroslav Dobrovolny. I am a researcher and also work as an osteopath. When designing neurofeedback training, we always begin with the ontogeny of the EEG and tailor the training individually using a diagnostic chart, precisely according to the specific needs of the client's brain, rather than the needs of the client's diagnosis. We believe this individualized approach is fairer to clients who pay for therapy than training based on general protocols focused on the diagnosis, where the success or failure of the training is not clear in advance. Now, let us move to the first part of this presentation, dissociation. First part of this lecture is dissociation. We developed the dissociation protocol in 2023 and have been collecting additional data since then. I would now like to present our hypothesis, which we will explore in greater depth over the coming years, and you are welcome to join us in this endeavor. These patterns are based on two key parameters, frequency and amplitude. When interpreted correctly, they can help us describe a client's symptoms with remarkable precision. They can guide us in selecting the appropriate training strategy and indicate what kind of change we may realistically expect. Based on our research, we have connected Porges' three types of dissociation with specific neurological patterns and the symptom profiles that belong to them. So now, we will look at three forms of dissociation. Type 1, focus. Type 2, panic. Type 3, collapse. Each card shows the EEG activity of the right hemisphere, the EEG activity of the left hemisphere, and a more detailed description of the symptom profile. It also includes guidance for training. What connects all three types is the need for safety, but each type expresses that need in a different way. So let us now take a closer look at the first one. The first type is focus. Its underlying message is, I do not feel, I remain on guard. Outwardly, the person may appear calm. Internally, however, the survival system is already active. Over the left hemisphere, we typically observe a fast rhythm with low amplitude. In this state, the left hemisphere remains alert, monitors the environment, evaluates the situation, anticipates, searches for escape strategies, pays less attention to those nearby, and seeks safety. Over the right hemisphere, we usually observe a fast rhythm with high amplitude. In this mode, the right hemisphere disconnects from emotions. The person stops feeling. The organism shifts into survival mode, energy is directed towards defense, and there is little capacity left for play, learning, or forming relationships. For this type, neurofeedback training is particularly effective when we decrease the amplitude of beta 2 over both hemispheres, while also reducing the amplitude of the dominant rhythm over the right hemisphere only. For this training to be effective, one condition is essential: the client must experience safety. The physiological state most commonly experienced here is, I do not feel. The second type is panic. Its inner message is, I cannot think. This is a state of emotional overwhelm. It is important to remember that in this type, not only does the emotional system begin to fall apart, but the capacity for thinking also deteriorates. Over the left hemisphere, we typically observe a slow rhythm with high amplitude. This pattern causes the left hemisphere to deactivate learned responses, suspend decision-making capacity, and lose the ability to think clearly. The person may also lose spatial orientation and experience an intense fear of losing control. Over the right hemisphere, we usually observe a fast rhythm with low amplitude. In this state, the right hemisphere becomes disoriented. Blood pressure, body temperature, and heart rate increase. Breathing becomes more difficult, and symptoms such as nausea and tremor may appear. For this second type, a very effective neurofeedback approach is to reduce the amplitude of beta 2 over both hemispheres, while simultaneously reducing the amplitude of the dominant rhythm over the left hemisphere only. Here, you can already notice the first important difference between the two types. In the first type, our attention was directed more towards the right hemisphere. In the second type, it shifts more towards the left hemisphere. There is another important difference. For the first type, it may be sufficient to offer safety. For the second type, that is no longer enough. Here, we need to actively create safety. There is one more important difference. For the first type, it may be sufficient to offer safety. For the second type, that is no longer sufficient here. We need to actively create safety for the therapy to succeed. The third type is collapse. Its inner message is complete disconnection. Collapse is no longer an overloaded system. It is a system that has begun to shut itself down. In this third type, we typically see a fast rhythm with low amplitude over both hemispheres. In this mode, the left hemisphere switches off thinking, disconnects the perception of space and time, reduces energetic activation, stops understanding, and, in a way, stops being present. The right hemisphere then disconnects fear, sadness, and pain. The person feels nothing. Rhythm is lost, and numbness and passivity take over. For this third type, an effective neurofeedback approach is to reduce the amplitude of beta 2 over both hemispheres, while at the same time increasing the amplitude of the dominant rhythm over both hemispheres simultaneously. And for this third type, even creating safety is not enough. For therapy to succeed, safety must be continuously maintained. So, we are looking at 3 types of dissociation. Type 1, I do not feel. Type 2, I cannot think. Type 3, collapse. What all 3 types have in common is the same neurofeedback foundation. The training is always aimed at reducing the amplitude of beta 2. Where they differ is in how we work with the amplitude of the dominant rhythm. In type 1, we reduce the amplitude of the dominant rhythm over the right hemisphere. In type 2, we reduce the amplitude of the dominant rhythm over the left hemisphere. In type 3, we increase the amplitude of the dominant rhythm over both hemispheres. The 3 types also differ in the form of safety they require. For type 1, safety must be offered. For type 2, safety must be created. For type 3, safety must be held. So, to summarize, with dissociation, the principle is clear. Safety comes first, and only then can we talk about performance, cooperation, or explanation. The first step is to notice the signals. We need to ask, does this person appear without emotion, without thinking, or completely disconnected? And then we verify that picture through the EEG. The next step is not to judge the state. We should not write it as resistance, laziness, or intentional behavior. We should understand it for what it really is, a specific state of the nervous system, and one that we can work with. And finally, we need to choose the right form of safety. Depending on the type of dissociation, safety must be offered, created, or held. We should not interpret the state as resistance, laziness, or defiance, but as a specific condition of the nervous system, one that we can understand and work with. Let's go to ADHD. Our research on ADHD started 2011 and has included over 500 child clients, 70% boys and 30% girls, aged 7 to 13. According to the ICD-based classification, there are 4 types of ADHD. 1. Inattentive type 2, anxious aggressive type 3, hyperactive type 4, impulsive type. We have assigned a specific neurological pattern and corresponding symptom profile to each of these types. In the remaining time, I will try to give you a clearer picture of each of these patterns. Among the frequency mature types, we include type 1, inattentive, and type 2, anxious aggressive. Among the frequency immature types, we include type 3, hyperactive, and type 4, impulsive. There is one more important distinction here. Type 1, inattentive, and type 3, hyperactive, are both linked to high amplitude. By contrast, type 2, anxious aggressive, and type 4, impulsive, are linked to low amplitude. So now, let us look at each type one by one. Type 1, inattentive ADHD. Let's start with type 1, the inattentive type of ADHD. This type is considered frequency mature, which means the brain rhythm itself is normal for age. The issue is not the frequency, but the amplitude. In other words, how strong the activity is. The main feature is increased amplitude of the dominant rhythm, most often at the top of the head and in the right hemisphere. In everyday life, this shows up as difficulty staying focused on tasks that are not interesting, distractibility, daydreaming, scattered attention, and often a feeling of not being fully present. A simple way to describe it is, they are looking, but they do not see. They are listening, but they do not hear. From a psychological point of view, this can be seen as a protective pattern. There is often some level of pressure to perform, together with an inner feeling, I am not good enough. The brain shifts attention outward, away from uncomfortable inner experiences like fear, anxiety, or emptiness. In simple terms, attention goes outward so the person does not have to feel what is happening inside. This is often linked to a freeze response, together with a strong need for connection. On the body level, tension in the neck may also play a role by increasing the effort needed for posture and sensory processing. Biological factors, such as gut imbalance or digestion issues, may also contribute. In neurofeedback, the goal is to gently reduce excessive activity where needed and support more balanced brain function. Type 2, Anxious-Aggressive ADHD. The second type is the anxious-aggressive type. Like the previous inattentive type, this is also frequency mature, which means the brain rhythm is normal for age. Again, the main issue is not the frequency, but the amplitude. In this case, the dominant rhythm shows low amplitude. In the frontal area, we may also see habituation without slowing of frequency, or sometimes a rebound effect. On the outside, these individuals may appear strong, confident, or even like natural leaders. But inside, there is often a high level of fear, usually linked to unmet needs for trust and autonomy. They may become very dependent in relationships and strongly protect their space. Their aggression is usually not true strength. It is a defense, a way to protect against emotional pain. In simple terms, it may feel safer to be the aggressor than the victim. They often seek attention, because attention gives them a sense of being seen and heard. They may create conflict or stay in opposition just to keep attention on themselves, because even negative attention is still attention. They also tend to need a role, such as the helper, the leader, or the rescuer. Without this, their sense of self can quickly weaken. Very often, they adapt others instead of being themselves, which leads to inner frustration. A simple phrase for this type is, "The dog that barks does not bite." From a psychological perspective, this pattern is often linked to early unmet needs, especially in trust and autonomy. There may be early emotional stress, with patterns stored deeply in the emotional brain. Typical inner messages can be, "Nobody loves me, I am not good enough, I am alone, I have to manage everything on my own." At the core, there is a strong need for connection, care, and safety, together with low self-trust and low trust in the world. In this case, therapy is very important. Neurofeedback is usually not the first choice here. A better starting point may include play therapy, dyadic therapy, craniosacral therapy, osteopathic treatment, somatic experiencing, EMDR or EMI therapy. Type 3, Hyperactive ADHD. The third type is the hyperactive type of ADHD. In this type, the dominant brain rhythm is not fully aligned with normal brain development. In other words, we see a more immature rhythm pattern. This immature rhythm is also linked with high amplitude. These clients typically show strong motor activity. They move constantly, fidget, get up, run, twist, play with objects, or move their legs and hands all the time. They often prefer younger children and younger environments. But the key point is this: these behaviors are not random. They are not just disruption. They are regulation. In simple terms, the child is trying to regulate their own brain state. By moving and stimulating themselves, they are trying to reduce excessive amplitude. When amplitude goes down, the brain rhythm can speed up, which helps attention. At school, these children are often seen as distracted or restless, even though they may be very intelligent. So the issue is not intelligence, it is energy regulation. They cannot hold attention for long, because too much energy is used in maintaining high amplitude activity. From a brain perspective, we also need to look below the cortex, especially the brainstem and limbic system, where energy regulation may be less efficient. Possible contributing factors can be at several levels. From a metabolic point of view, toxicity, gut dysbiosis, parasites, poor nutrition, or imbalance in supplements. From a neuromotor point of view, delayed maturation of brain stem systems and persistence of primitive reflexes, sometimes related to cervical restriction. From a neurosensory point of view, restrictions in the skull or cervical spine affecting sensory processing. From a psychological point of view, unmet needs for connection, safety, trust, autonomy, and love. The nervous system then organizes around protection from overwhelm and fear of separation. A simple sentence that describes this type is, "I want to stay a child because growing up feels too overwhelming." In neurofeedback, the approach is to reduce excessive amplitude across hemispheres when needed, and to normalize dominant rhythm activity. The table-based protocol can be used as a starting point for general stabilization. By reducing amplitude, we often see an increase in rhythm stability and speed. Type 4, Impulsive ADHD. The fourth type is the impulsive type of ADHD. Like the hyperactive type, this also shows an immature EEG rhythm. However, in this case, the amplitude of the dominant rhythm is very low. Let's look at the clinical picture. These clients often show more infant-like behavior. Their performance can be very uneven. School is usually not very interesting for them. They prefer play. We also often see emotional immaturity and poor regulation of reactions. One important point is this. What looks like immaturity is often a nervous system that has not yet developed full stability and regulation. Under stress or overload, their behavior can become more difficult. Frustration or feelings of inferiority can easily lead to emotional outbursts, but in a playful and safe setting, they can often learn very well. A simple sentence that describes this type is, I want to stay a child. I don't want to grow up. I need someone to take care of me. Possible contributing factors can again be found on several levels. From a neuromotor perspective, there may be delayed brainstem maturation and persistent primitive reflexes, sometimes linked to cervical restriction. If the body cannot complete normal motor patterns, primitive reflexes may not integrate properly into postural control. From a neurosensory perspective, restrictions in the musculoskeletal system may affect sensory processing, including vision, hearing, touch, smell, and taste. From a psychological perspective, we often see insecure attachment patterns. The inner experience may include, I cannot become independent, I cannot take responsibility, I still need someone to take care of me. This often reflects unmet dependency needs in early development, which can lead to a persistent sense of being stuck in an earlier stage. In terms of therapy, neurofeedback is not recommended as a primary approach for this type, because cortex not have the energy for this type of training. More suitable interventions include INPP, bilateral integration, neurosensory therapy, play therapy, EMDR or EMI, somatic experiencing. Let us summarize the ADHD section. We have presented 4 ADHD types based on electrical brain activity. For each rhythm pattern, we have linked a symptom profile and a therapeutic approach, so your work can become not only more effective but also more precise. Let us review them once more, very briefly. The inattentive type, the dominant rhythm is mature, with high amplitude. Here, neurofeedback is suitable as a primary therapy. The anxious aggressive type, the dominant rhythm is mature, with low amplitude. Here, neurofeedback is not suitable as a primary therapy. The hyperactive type, the dominant rhythm is immature, with high amplitude. Here, neurofeedback is suitable as a primary therapy. The impulsive type, the dominant rhythm is immature, with low amplitude. Here, neurofeedback is not suitable as a primary therapy. Thank you very much for staying with me through this lecture despite my poor English. I hope it will help you work more effectively with your clients. If you want patterns for dissociation or ADHD, ask me or my wife Bibiana. Thank you for your attention. And now, it is time for questions, and perhaps some answers as well. You can download the color chart for dissociation or ADHD for free from our website, newbfb.eu, or simpleneurofeedback.com, or biofeedbackinstitute.com.